We can go ahead and get started. So while Dr. Persse is, I guess, moving to a different location, what I wanted to kind of start off here with was a short introduction about Dr. Persse, and then we can kind of get into the questions that you all had submitted, and then some other students that weren't able to be here today. They also submitted some questions in advance that I'll ask on their behalf. So with that, we can go ahead and get started. Again, it's an honor for you to be with us here today, Dr. Persse. We're really excited to hear what you have to say about our city's response towards COVID-19. A little intro on Dr. Persse. His career in medicine started with 10 years experience as a field paramedic and a paramedic instructor in upstate New York and New Jersey. After receiving his pre-med training at Columbia University in New York, he then attended Georgetown University School of Medicine. Graduating with honors in emergency medicine from Georgetown, Dr. Persse then completed residency training in emergency medicine at Harbor-UCLA Medical Center in Torrance, California. In 1996, after serving as a medical director of the Los Angeles County Paramedic Training Institute and the assistant medical director of the Los Angeles County EMS agency, Dr. Persse returned to Houston to assume the role of the director of emergency medical services for the city of Houston. In May in 2004, he was appointed by City Council as Houston's Public Health Authority. In his role as Public Health Authority, Dr. Persse is responsible for the medical aspects of clinical care, quality management, disease control, and public health preparedness. He is also a member of the Board of Directors for the Southeast Texas Trauma Regional Advisory Council and the National Registry of Emergency Medical Technicians. It's great for you to be with us today, Dr. Persse.
Well, first of all, let me say thank you for having me, and let me also apologize. We had this scheduled one time before, but quite honestly, I think the mistake was at our end with the scheduling snafu. And what I'm not happy to tell you is that our computers are still making that mistake, and so there are things which are on my calendar which suddenly disappear, and we're still trying to figure out how that's going, why that's happening. But anyways, it's an honor for me to be with you all and give you some insights into what we're doing with this once in a century pandemic. And, there isn't a book. Well, we've had plans for pandemic flu. We didn't have plans for, and those are about 20 years old, actually. We didn't have plans for a pandemic of a virus where 40% of the people have no symptoms. So that was a real game changer. Let me just warn you right this minute, I'm about to transition out of my vehicle into my office. So hopefully my connection by phone will continue, but if it should happen to break, I will be right back with you. But anyways, so I don't know exactly how you want to begin, but I've got all kinds of answers for all kinds of questions.
Yeah, I mean, I think where a good place to begin would be, just kind of getting your take on how our city is doing against COVID-19. I know the governor recently, lifted the mask mandate, and I know it might be a little too soon to see any effects of that. But, what are some trends that you've seen in regards to COVID-19 in the last 2 months? And I think that would be a good starting place for us today. I think his connection is kind of coming off.
It hooks up to the car audio, and as soon as I get out of the car, the video keeps going, but you can't hear me anymore because I'm no longer near the microphone. So yep. I'm sure that there is a button that I press to fix that, but I'm over the age of 50, and so I don't know what that magic trick is. But okay, so your question was overall, how are we doing? Well, in some aspects, we're doing well. One thing is that we know that nationally, one of the most at-risk groups for death and dying have been nursing home residents. And the national average up through late November and December, 40% of the deaths in the United States were from nursing home residents, 40%. Most recently, in late February, that number had dropped from actually 39 point something percent down to about 27%. So as a nation, we have done better in protecting our nursing home residents. But here in Houston, we never got above 20%. Our highest was, I think our highest is just a hair under 17%. And the reason that we were able to do that is very early on, the health department put together teams, and we actually married members of the fire department who are used to going to nursing homes. And in fact, the nursing homes recognize a lot of the firefighters because they get called to nursing homes so much. They certainly recognize the uniform. We managed those along with public health folks to get into the nursing homes. And we actually went to each of the 400 nursing home and long-term care facilities in a 3-week period in Houston to go over all of their infection control procedures and in detail. And what we found was that some of them were doing a really good job up front. Some of them thought they were doing a really good job up front, but there were things that they had missed that you can't really blame them. They wouldn't know it unless they were in our business to have recognized that that tactic that you have actually won't work, and here's why. And then they would have the aha moment and they would fix it. And then we had a group that had really lousy systems in place, but thought they were doing an okay job. They had no idea how terrible they were. And then, of course, unfortunately, we had a small group who just had a terrible situation and they didn't much care. And so that's just the sad truth of it. So it was really important that we went in there and fixed what we could, and then learned who we could predict were going to be the problem locations, so that we could then keep very close tabs on what was going on in those locations. And sure enough, not a big surprise, most of them actually turned around and did fairly well. Some of them did not, but we were at least alerted to it, so we stayed on top of it and caught problems really, really early. And I think that's why we had less than half, maybe even 2/3 fewer nursing home deaths than the rest of the nation. So that's one good thing that we did. The other thing we did, which is probably just as well as anybody else, is we tried to get out ahead of this with the public messaging, but as unfortunately, as you know, this then sadly became a political issue, and people decided to interpret a public health crisis as a political battle. And that really, really set us back. And that continues, as you know, to be a big challenge for us. Today, with vaccine here, the timing of a lot of things in public health is very important. And so the governor lifting the mask mandate and the restrictions on occupancy just as the vaccines get here is a challenge, because it's a mixed message. On one hand, it's good news that the vaccines are here, but by the governor lifting things, it almost says to some people that, oh, it's all over, we're done now, it's good. And we're not there yet. We might be there in a couple of months, but we're certainly not there yet. And unfortunately, the communication that has gotten through to some people is that this is all over and we can just go back to normal now. And we're actually not there yet. So a mixed answer to your question. Some things we've done well and some things we need to do better.
Yeah, and I think that's actually a great segue for our next question here. I actually have it on a PowerPoint. And I think Hannah is going to go ahead and answer that question. Can you introduce yourself, Hannah, and then ask the question?
Hi, thank you so much for taking the time to speak with us. I'm a first-year medical student at Baylor, and I was just curious, as you can see here, what aspect of our response you're most proud of, and you sort of talked some about some of the things we've been doing, and also what has been some of the most challenging parts of guiding our city at this really challenging time.
Okay, so one of the things, so I already talked about our success with the nursing homes, but the other success that we had that doesn't get a lot of play in the public, and there's no really reason for it, but for you all, it would be important, is that in February of last year, when this was first spooling up, Bill McKeon, who's the CEO of the Texas Medical Center, held a meeting in his office, and this is before we were social distancing or wearing masks or any of it. So we gathered together in his office. And he, of course, has a very large conference table. And we have representatives of all of the Texas Medical Center all the large Texas Medical Center institutions. So Baylor was there, St. Luke's, Herman, UT, Methodist, Harris Health, Texas Children's, MD Anderson, I believe, was there. The VA was not, UTMB was not. But anyways, we had most of the folks that were there. And generally 2 or 3 people per institution. And we made a commitment to each other that we were going to work together through this. And so what we wound up doing is we wound up meeting that same group of folks. It's a little bit smaller today, but still it's a group of maybe 30 people. And we will meet in a virtual environment twice a week. And people who are in those meetings now routinely include Bill McKeon himself, Stephen Williams, who's the director of the health department. So I'm the doctor, I'm the public health authority. Stephen Williams is the director. So he's the one who manages the budget and all of those sorts of things. So Stephen Williams is there. Our counterparts from Harris County Public Health. So Dr. Umair Shah had been on it, but he of course has gone on to become the Secretary of Health for the state of Washington. But we have representatives from Harris County Public Health as well. Dr. Klotman, Dr. McDivitt from Baylor are on it routinely. We have Dr. Callender from Memorial Hermann is on it. Dr. Persse from Harris Health is on it. And there are others, but there are people in the very highest leadership roles. And we meet twice a week. And every time we meet, there is something that we all need to get on the same page with. And it's kind of amazing that here we are nearly a year later, and twice a week, there's something we need to all be talking to each other about. And so that has, in a large regard, been important because hospitals, as you know, are businesses to some degree. And in the off season, I'm going to call it, during regular times, they can be in fierce competition with each other. They really want those insured patients with, whatever disease it is that's going to have the highest profit margin, right? But during a disaster, we need to leave those jerseys at the door and we need to all be on one team. And so this has really helped us. And so I don't think that gets much attention, but I think that you all need to know as future healthcare leaders that, you're going to be in a business environment in the future, but also when disasters strike, we need to be able to get past that and come together. Now, if you think about it, with the elimination of elective surgeries for several months, hospitals lost literally tens and tens, if not hundreds of millions of dollars. And so the financial impact on the hospitals from the COVID pandemic is nothing to ignore. It's a very serious issue, but we're figuring out ways as a community we can get past that. So that's probably one of the other things that we're most proud of that doesn't get much attention. The most challenging part I already sort of talked on, and that's the messaging to the public. And so in public health, we don't have a whole lot of tools. We've got our clinics and we've got some vaccines, and we don't do a lot of primary care. That's for others from public health. But one of our biggest things is public messaging, and it's really difficult to get out the message when our messages are easily confused because they're a little bit more scientific than the public is used to having to understand. It's difficult when you have reporters who want to create a story where one doesn't exist. And then, of course, it even becomes more doubly when you've got people who actually have a political agenda to either make things look better or make things look worse. And they take your words and they spin them to their purpose. And so that's probably been the most difficult thing, has been the public messaging.
Mm-hmm. And I think kind of a flip side to Hannah's question, Dr. Persse, is, what are areas that you feel like, we as a city could be doing better right now, in this response to COVID? Or what are things that, did not go as well as planned, and how can we prepare ourselves for the future, future types of pandemics like this?
So you know what, I'm gonna take your question, I'm gonna spin it a little bit in that if we could go back and do this over again, what would I do different? Is that fair? Can I do that?
Yeah.
So one of the things, and we talked about this early on, was with contact tracing. And I think this is an important concept for you all to understand, is when we talk about contact tracing, so you have, person one who is infected with the new disease, and we want to find out who they may have passed it on to. You interview that person, you then interview the people whose names they give you, and you try to contain the spread of the illness. Now, if you remember back in the very beginning, the first handful of cases that we had here in Houston were from a group of people, it was about a dozen folks who had been on an Egyptian river cruise where somebody on that boat was infected with the COVID virus, or the coronavirus rather, and spread it to everyone, basically everyone who was on that river cruise ship. And then many of them returned here to Houston. We did the heavy, duty contact tracing and disease containment. And we actually contained the virus with those people. We have never found any spread from those 12 people. That's a little bit different from the next phase, which is disease mitigation. And that's what we've really been in ever since the rodeo, the security officer at the rodeo who was determined to be COVID positive. Now, here's the other thing to keep in mind about him, is that when that came out, everybody quickly jumped to, oh my gosh, he was at the rodeo. How many people did he spread the virus to? And that was the wrong question. Because if you look at the timeline from when he was at the rodeo and when he developed symptoms, and this again was with our contact tracing, the question isn't who did he spread it to at the rodeo? The question is who did he get it from at the rodeo? Because he didn't become symptomatic until 4 days later. Now we looked at what he did basically for the previous 2 weeks. And in the time between when he was at the rodeo and when he developed symptoms, he hadn't been hardly anywhere. He had worked as an officer at a construction site. So he's that officer standing out there directing traffic. He wasn't really around anybody. And I can't remember what else he did. It was a year ago, but he had done something else. And other than that, he had just basically been at home by himself and, with his family, with his wife. So between the rodeo and when he developed symptoms, he hadn't been around very many people at all. And the timing is such that he probably caught the virus while he was at the rodeo, not who did he spread it to. But to get to your question, since then, we've tried to do all this contact tracing, and we've had now, tens of thousands of cases. And the public is very reluctant now because they don't want to give up their contacts. So we've wasted a lot of time and effort on contact tracing of the entire community of Houston. And the reason sorry, it's a long answer, but in the beginning, you can see how contact tracing can be very, very effective in disease containment. But once the cat's out of the bag, the contact tracing is an academic effort. It is no longer really a containment strategy because you just have too much spread, too many people. There is a stigma that comes out about the illness, in this case, COVID. People won't tell you who their contacts are. So if we had to do all over again, I wouldn't have spent nearly as much time, effort, or money on the contact tracing of the whole population, but I would have tried to focus it more on areas that we would be most worried about, the most vulnerable.
Mm-hmm. Yeah, I mean, I think at the beginning, there was a lot of confusion. I remember, especially when that rodeo report came out, I didn't know what was going on. I think it was a very, scary time. And so, now that we've come out of that, and I think vaccines are on the way, and a lot of people have already, received their first dose. One of our students, unfortunately, she cannot make it today. Jabrea Bennett, she's one of our representatives from the University of Houston. She wanted to ask, what measures are you all taking in order to ensure that implicit cultural biases are not preventing equal healthcare access during the pandemic, especially where it concerns COVID-19 vaccination distribution?
Yeah, so this is a great question. And this is one of the things that we spend, even outside pandemics, that we spend a lot of effort on. And the short answer to this question is that we know that people will gravitate towards others in their own cultures, right? And so one of the things that we do is we try to work closely with the faith community, and we also work closely with clinics that are in different cultural communities, especially those that speak languages other than English, those that have clinicians that are, for example, we work closely with the Vietnamese community through the clinics that employ Vietnamese and Vietnamese speaking physicians. Same thing with all of the others, the Latinx community, the African American community, and many others. So what we try to do is to get into the communities and the cultures and have them guide us. So for example, we're giving a lot of our vaccine. Well, I would say a lot. We're giving vaccine because there isn't a lot for anybody to have just yet, but there will be very shortly. But we are giving vaccine to clinics that are embedded in those communities and letting them get the word out. And then we do the other things, the more global, like all of our messages are done in, I can't remember how many languages now, like 15 or 17 different languages. All of our messaging is translated, and we work with all of the different public, the news agencies and the newspapers and stuff in a variety of different languages, and trying to get the message out that way. But we don't just take our message and translate it. We take our message, we then have people from that community not only translate it, but also nuance it the way it needs to be nuanced, because I don't understand those sorts of things from other cultures, and how phrases, like you can take a phrase and you can translate it, and it will not have the exact same meaning, right? Mm-hmm. And so we try to work close to the folks who are going to be able to understand what our message is, and then get it so that it will be received in the way that we intend it.
Okay. Thank you for the answer, Dr. Persse. I think Hiba posted a question in the chat. You want to come off of mute, Hiba, and ask it?
Hi, Dr. Persse. Thank you for coming down and speaking with us today. We really appreciate your time. I was going to ask, when do you think we can get herd immunity?
So this is a great question. A lot of people ask this question and they want a date, July the 1st. They want a date. When are we going to be at herd immunity? You all are far smarter than that. You know what's going to happen. And so let's think about this. What's going to happen? We continue to have people who are getting infected, and they're, the majority of them, thank goodness, are surviving and, getting over the illness, and they then become immune. Now, we don't know how long that immunity will last, but they're getting certainly at least short-term immunity, probably lasting 3 to 12 months, right? So that will contribute to herd immunity. And then we also have an increasing number of people being vaccinated. So today, our most recent numbers, we think we've got about 16 to 19% of folks have already been infected and probably have some immunity. We're just short of 10%. So let's round that up to 20% of the people have been infected. Let's round it up to 10% of people have been vaccinated. So let's say 30% of the population is currently immune. So that's going to slow down the virus. It's not going to stop the virus, but in some time here, we'll be up to 40%, and they'll be up to 50%. And as we move up with that increasing amount of community immunity, not herd immunity, but community immunity, the virus's ability to spread is going to slowly come down. The problem is going to be when the spread of the virus gets low enough that people think that we've hit herd immunity when we really haven't, and they stop going to get vaccinated. So eventually we will get to herd immunity. We're going to get to it one of two ways. We're either going to get to it by people getting vaccinated, or we're going to get to it through people getting sick. And clearly it's going to be a combination of both, but nevertheless, we would far rather that we got to it more because of vaccination than because of people getting ill. My fear, however, is that as our rate of immunity in the community is going to be increasing here in the short term, more so dependent on the amount of vaccine coming in, because that's having the biggest impact. I mean, overall, it has a small impact today, but it has the potential to have the bigger impact over the coming weeks and months. But if people stop getting vaccinated, that will then sort of plateau. And the magic number, we believe, with the current strain that is the predominant one in the Houston area, is in the 70 to 75% range. If the UK variant winds up taking over, that's going to mean we're going to need to get higher into the 75, 80, maybe 85% range. And if people aren't going to get vaccinated because they think this whole thing is over, it's going to be really, really difficult to get there. And in the end, we'll wind up getting there due to infection as opposed to vaccination. So to your question, I think your question was, when do I think we're going to get there? I'm thinking, I'm sort of planning in terms of family vacations and stuff. We're not planning on it until fall. We could hit it as early as June or July. But I think what's going to happen is, as the hospitalization numbers in particular come down and the media picks up on that and they get on this whole bandwagon about, yay, it's over, hippie, then people won't go get vaccinated anymore. And we're going to wind up with this slow burn. Instead of putting the fire out, we're going to have this smoldering problem going on for several more months.
I do have another question, but I think so did Jeff. So if you want to go first, Jeff.
Oh, you can go first. If it's a continuation, you might as well go.
I don't. Well, it's how long will the vaccine be effective against COVID-19 for?
Yeah, that's a great question. We don't know yet. So the people who are very first vaccinated with it back in the beginning of the Pfizer trial, which preceded the beginning of the Moderna trial, those folks are being tracked to see how long they continue to produce antibodies. So that's been less than a year. Mm-hmm. What I've heard most recently is most of them still are producing quite a bit of antibody. So we're going to have to wait and see. The hope is, the anticipation has been that it would be at least a year. But there is, remember, this is mRNA. And so this is not a vaccine platform that we've used in huge numbers ever before. There are those in that industry, those scientists, those virologists, those vaccinologists, who think that we could get maybe 5 years of immunity. But we quite honestly don't know. Mm-hmm. It looks like so far, as of today, it looks like you're going to get almost a year, because it's only been almost a year since people first got vaccinated.
Thank you for answering my question. Jeff, you can go next if you like.
Hi, Dr. Persse. My name is Jeff. I'm a third-year medical student in McGovern. I just had a question kind of in the psychiatric realm. So the current literature kind of suggests that, the pandemic is creating a lot of psychiatric symptoms amongst all populations that can potentially sort of have very catastrophic effects in the future. And additionally, we've kind of seen this ER system been overrun in Houston and, other places as well, given the pandemic as well. So my question is basically, given our, we have a county hospital that has 274 beds, HCPC, the Harris County Psychiatric Center, and that's our biggest hospital. That's already kind of being, filled up every day, trying to find beds for patients that really need them. So given that we, anticipate these psychiatric effects worsening in the future, does the city have any tangible interventions right now that are aimed at sort of mitigating these effects? So, 10 years down the line, 5 years down the line, we don't have this overrun psychiatric system as well.
Yeah, so sadly, the city doesn't. So mental health and the care of those who are suffering from mental illness is not something that the city does, nor have we ever really done it. The county through HCPC and through Harris Health have done the most of it, right? And then there's the private industry part as well. And so that's where the mental health care lies. So the city, that's not our, that's never been our lane, if you will. I wish that it was. I'm not a psychiatrist and that's not my area of expertise, but as a public health person, I clearly see the need that you're referring to. And you're also quite right in that it is just the number of patients with acute emotional, psychological, and mental health issues has just skyrocketed. So I'm not just talking about the chronic schizophrenic who is now more stressed out and in addition is probably having more difficulty getting their meds. I'm talking about people who were previously healthy from a mental health standpoint, healthy or at least appeared to be healthy, but now because they've lost their job, they've got family dynamics, they're just afraid of the virus, what have you. It's pushing them beyond a limit that they didn't know that they had. In a community, here in Houston, but really across the United States, that is just inadequately prepared to provide the type of support that somebody like that needs. And if you think about it for a moment, not trying to value one over the other, but the new onset mental health patient today is probably far more likely to be somebody that we could cure, if I can use that term, because they're having an acute problem, for which they need help getting through, as opposed to somebody who's already been schizophrenic for 10 years and now they're just suffering, just increased complications. I'm not trying to say one is more important than the other, but what I am trying to say is that, to your point, is that if we, because we don't have the resources today to jump on this, the population of people with mental health problems is going to grow far beyond the 10-year schizophrenic. We're going to be, sort of creating a whole new population of people who are at high risk for developing chronic mental health issues that if we were able to address them early on, we could return them to a normal lifestyle and just, go back to dealing with that size of population of mental health patients in the community that we've always dealt with. But we've done such a lousy job with this group that now that we're adding on a whole bunch more, a lot of their needs are just going completely unanswered. And so when I talk to my colleagues who are working in the emergency department, my background is emergency medicine, as you heard, and I've been doing this 30 years. We have never had adequate mental health resources. Not only here, my training, as you heard earlier, I spent a lot of years in California, and our mental health assets, not only here in Houston, but across the United States, are just shameful, just totally inadequate. And don't get me on my soapbox with that one, but with the pandemic, we're really, it's a perfect storm for making that worse. Now, trying to find a half full part of the glass is, in our society, the nice to haves don't get a lot of attention, but when something becomes a crisis, it finally gets attention. So trying to find a silver lining in this is perhaps the impact of the pandemic on mental health patients and the surge of mental health, mental illness that needs to be addressed in this country. Maybe we'll start getting the attention that it needs, and we'll actually get some tangible improvements to the system.
So quick follow-up. So when you say that the city is, that is kind of not in the city's lane, is the limiting factor the funding or sort of like the manpower behind initiatives like that?
No, so the limiting factor is that, so between the city and the county, there are things which sort of we do, and then there are things that the county does. So with the city, for example, the Area Agency on Aging is a city-run program, but we cover everyone in Harris County, even though that's outside the city limits of Houston. Mosquito control, on the other hand, we have mosquitoes in the city of Houston, but Harris County runs the mosquito control district and does all the mosquito control. And similarly with acute and chronic health care, the county has Harris Health and HCPC. And so that's a county function. Whereas with the city, we have a lot of clinics, but our clinics are mostly, really, we have tuberculosis clinics, and we have county patients that we cover in our tuberculosis clinic. We have a Hansen's disease clinic. So we cover all the Hansen's disease patients. And for those of you on, that's leprosy. And so the Hansen's disease clinic is for both the city and the county. And we've got a couple of specialty clinics like that, for which we do both city and county, but the county does, well, they've got Harris Health and HCPC. And so that's why that's in their lane as opposed to our lane. It's a little bit of a divide and conquer mentality. Although conquer is a loosely used term in this discussion.
Yeah, no, I think that's a really important question, because I think things that we've heard directly from students on our campuses is the need for access to mental health care, because I think that's a very growing issue on all of our campuses. I think a follow-up question, would kind of be, what can we as student leaders today do to, directly help with, this fight against COVID-19? What are some things that you envision that we could do as leaders on our campuses, as well as people that live in the city of Houston?
So you want the impossible answer? Is yeah, if you could tell people that are your age, your colleagues, not your student colleagues, but your generation colleagues, please don't go to clubs. If you could just take care of that, that would be a help. No more drinking, no more going to clubs. Also, no touching, no kissing, no holding hands, none of that. All right, just stop all of that. And of course, that's I'm being a little bit funny, but yeah, obviously, clearly, that we've seen more recently how it is the 20 and 30-year-old age groups where we've seen the greatest increase in viral activity, and that's because let's face it, you guys are in those age groups now, and I'm not so old that I've forgotten, but you're a very social animal at that age, right? A lot of friends are really important to you. You're developing intimate relationships with your future spouse, or you've got relationship with your spouse, and you've got your set of friends and things. It's a very social time in your life, and that's great. That will end as soon as you have children, by the way. But a couple of people are laughing, so they know what I'm talking about. But nobody wants to take that away from you, right? But during the pandemic, this is why we're seeing the increase in the viral activity, and that's most people in that age group, they do fine with it. Not everybody, but most people do fine with infection. The problem is you bring it home to grandma, you bring it home to your grandfather, you bring it home to your elderly aunt, you bring it home to your little brother who's got, diabetes, hypertension, obesity, some congenital, genetic problem that causes him to have all kinds of respiratory problems that are very rare and hard to manage. And you give him the virus, and now he's in big trouble. So that's where the problem lies. So there's that. And then the other thing I would say is that, there is a lot of talk that this pandemic, the first one in 100 years, it's not going to be another 100 years before we have another one, right? There's a lot of theorists who think that we're going to have our next pandemic again, within the next 20 years. The world is a smaller place, all the talk about how this pandemic began. If you look at, and here's the other thing, and I agree with them. So if you look at the 1918 flu, and we didn't have anything for many, many years. But then, then we had SARS, and we've had MERS, and we had H1N1, and we had chikungunya, and we had Ebola. Those are all in the last 15 years, right? Now, this is the first one that truly became a pandemic. I mean, H1N1 did, but unfortunately it didn't have the devastation that we had anticipated or feared of. But the others didn't. Now, the others didn't. SARS and MERS in particular didn't. SARS especially. SARS is a really scary virus, but that got stopped through disease containment at a huge level. And I really got to, give it to the folks in Hong Kong and in Toronto in particular for having stopped that. because that had high risk for exploding into what we're dealing with today. So for those who think that we're going to have another pandemic in the next 20 years, I don't think they're wrong. So where are you going to be 10 years from now? Right? You're going to be in leadership roles in this community. So I applaud you for, taking the time tonight to have this conversation with me and try to learn what you can from me, because one of you is going to be in my seat 10 years from now. I will have retired. And I expect you to look out for the people in the nursing home, because I may be one of them.
For sure. And I think one question earlier, Dr. Persse, that you touched on was you guys are directly going to these, areas of faith to kind of target these, different populations. I think one thing that I've seen as an educator is kind of this misinformation about vaccination, right? A lot of my students or even coworkers that I work with sometimes have said, like, I don't want to get the vaccine because I'm scared of the adverse effects. Like, I don't want my face to get deformed and things like that. Is there things that, the city is doing to kind of quell that kind of misinformation? Because I do realize that it is, a serious concern among many communities.
Yeah, and so obviously we're doing the public education campaigns, and talking with the major media. We're also meeting with, so for a while there, we were meeting with we continue to meet, we were meeting with the school systems and with the faith-based leaders at one point early on about getting the message out. This was before vaccine, but just about, the importance of washing your hands and mask wearing and social distancing, those sorts of things. Then the schools became their own, they started having their own sets of problems. Now we still meet with them weekly, but we're not talking about vaccines so much at this point because the schools have had other problems in terms of disease containment on campus. There's a tremendous amount of politics that go on in schools, which I never understood before, but I certainly appreciate now. And today, we don't have to educate them about the benefits of the vaccine because they got more teachers and staff members that are banging on the door to get it than we've got vaccine to give. But we will get to the point where we've vaccinated everybody who wants to be, and then we need to start, educating folks who are a little bit more reluctant. The faith-based community, for a while, they were worried because, and good reason, because their congregations and their, gathering was restricted by the governor. And also, let's face it, most of the folks who go to faith gatherings are older people. And so, that community got educated pretty quickly about the dangers of gathering. And so they had a different set of problems. And again, today, the elder population is clamoring to get vaccinated. So we don't have the problem of, who's going to listen to them wanting to be educated. So as we move forward, it's really going to be the folks in your age groups that I anticipate are going to be the ones that we need to start educating. And my anticipation is that, most people in their 20s and 30s, forgive me for what I'm about to say, you're really smart. At some point in that between 20 and 40 years old, you start becoming jaded. You go from somebody who wants to soak up everything you can learn to somebody who now has ideas that are set and you're not willing to change them. And whether that be about, who's the better football team, the Texans or the Dolphins, or, it's good to get vaccinated. No, it's not. So, you get to a point in your life, it's somewhere in there where you start having these firm beliefs in things. And with what's going on today, with the politicization of public health, that's going to be the challenge, right? And so all I can do is try to give people the facts in ways where they can digest it. So, for example, we when it comes to vaccines, I tell people, okay, let's look at some simple numbers, something that people can get their heads around. If you take the number of people who've been infected, that we know are infected in city Houston or Harris County, and you divide that into the number of patients who've been admitted to Houston area hospitals. These are two numbers you can get off the web, wherever you want. And you divide those two, you're going to find out it's about a 10% risk. So about 10% of the people who we know have been infected wound up in the hospital. But you know what? There's a problem with that. We know a whole lot more people got infected than got tested and were counted. So let's take that 10%, let's cut it in half, okay? Tell you what, let's cut it in half again, down to 2.5%. And then you know what, let's shave a little bit more off of it because it makes my numbers easier. Let's say it's 2%. Let's say you have a 2% chance of being hospitalized if you're infected with the COVID, with the coronavirus. Okay, so everybody can kind of get their head around that. It makes about 1 in 50 chance, right? Now, if you're hospitalized, again, you look at the number of people who've been hospitalized, you know, people who died in the hospital, well, it's just short of 10%. It's like 8.9, 9.2, something like that. It's a little bit, so let's round, just to make it easier, let's round it up to 10% for my conversation. So if I get infected, I got a 1 in 50 chance of being hospitalized, and then a 1 in 10 chance of dying. Okay, what are my chances with the virus? I'm sorry, with the vaccine? Well, with the vaccine, you've got a really high chance of feeling nothing after your first shot. And after your second shot, you've got a really high chance of feeling crummy for about a day, maybe 2. And yes, you're going to feel crummy. And having been through it myself, I couldn't sleep one night. I tossed and turned all night. Woke up the next morning, couldn't really tell you what was wrong, but I just felt crummy. That was the best way to describe it. My wife told me I felt like I had a fever. We took my temperature, it was 99.1. I took a couple of Tylenol, I went back to bed, slept another couple hours, woke up, and I felt fine. She said, you still feel warm. Took my temperature, 99.1. All day long, I'm feeling fine. Just, I'm back to normal. She keeps telling me that I feel warm. Kept taking my temperature, 99.1, 98.9, 99 even. By 8 o'clock that night, all of a sudden, wow, all of a sudden, I actually feel better than I felt all day. Fever's gone. It wasn't even a fever, right? Fever, that's not a fever. 99 is not a fever. But whatever little temperature I had went away. Okay, so that's, you know, that's what you're going to have, right? Now, you have a really small chance of having an anaphylactic allergic reaction. Well, what is that risk? Well, if you look at both the Pfizer and the Moderna, it's about a 1 in 100,000 people who have gotten those vaccines have had an anaphylactic reaction, and none of them have died. So let's go back. If I get the coronavirus, I got a 1 in 50 chance of getting hospitalized and then a 1 in 10 chance of dying. If I get the vaccine, I've got a 1 in 100,000 chance of having an allergic reaction from which I'm not likely to die. I'll take my chances with vaccine any day of the week. So to answer your question, I'm trying to take all this complicated stuff and boil it down into something people can get their heads around and understand so they can then make a decision. At the end of the day, they have to be the ones making the decision. I can't tell anyone. And certainly the more I try to tell people what to do, the less they're going to listen to me.
Mm-hmm. Yeah, I think better, at least from the numbers you gave me, I think it was a lot easier for me to understand, how effective the vaccine is going to be at, potentially helping me keep my life. As our time comes down here with Dr. Persse, is there anyone else that has any outstanding questions?
I have a question again, and maybe more than one, however much your time allows. Please don't feel pressured to answer everything. So one thing that you were talking about just now is how our generation is probably going to struggle the most with educating themselves on the vaccine and the importance of taking it. So what can we do as student leaders, or what can the city do, or what can be done to make the information regarding the vaccine and its benefits more accessible and digestible to educate those who are misinformed, especially those in our generation?
So you're not going to like my answer. I would turn around the question. I would ask you, because just like I'm not Vietnamese, I'm not 20 years old anymore. So I don't know the best way to get through to folks that are your age. I need to ask somebody your age, what is the best way to communicate with other people your age? And not only, which social media platform, which is an answer a lot of people would give, but beyond that, here's what it just kind of goes to the translation that I spoke of earlier. Here's the information, and let's just take the numbers that I just did now, right? Okay, that little back of the napkin math type thing. How do you translate that into something that a 20-year-old is actually going to take the time with all the bombardment of information and entertainment that is the life of a 20-year-old today? How do I package that in a way that they're actually going to stop everything else and pay attention to this? And as a 61-year-old, doctor guy, I don't know the answer to that question. I need to ask somebody like you. How do we get that message? How do we package it? How do we put it forward? How do we deliver it? And I need to ask you, and this goes back to earlier about the culture question. I have to ask the people who are in that culture how to get the message out. Because again, if I just tell you something, they're like, you need to get vaccinated. You right now, go get vaccinated. You're not going to get vaccinated. It's the last thing you're going to do. So I need to find out from somebody your age. So sorry, you need to answer that question on your own.
No, that's okay. Gave me something to think about. Another question I had, which was actually from my dad. A lot of people want to know which vaccine is better, Pfizer, Moderna, or Johnson & Johnson.
So this is a good question. So boy, talk about misinformation. The Pfizer and Moderna vaccines came out with, the 94.5 and 95% efficacy ratings, right? And what that meant was that in the groups that got in the people that participated in the trial, half got vaccine, half did not. And as they tracked them, people became ill. Now, how did they define that, right? And so when they looked at who met their definition of having gotten ill, 95% of the people who got ill were in the group that did not get did not get vaccine. And 5% were people who did get vaccine. So that's where that number comes from. And Johnson, they define their outcomes differently. All right. And I should be able to, I don't want to tell you I'm wrong because I've got my own head confused as to whose outcome was what. But the outcomes were not the same. It wasn't the same study design. And in addition, when Johnson & Johnson did their study, we now had variants around the globe because they did it, multinational. There were variants that were out. Pfizer and Moderna didn't test in an environment where there were variants. And so when you look at the 72%, which was the US number for Johnson & Johnson, you really can't compare it to 94.5 because it's not an apples to apples comparison. Different outcomes, different definitions of the outcome, and at a different time when there were different viruses circulating. So here's the deal. What we do know, because again, they sort of, when you measure your outcomes early, but let's take those outcomes for a second. How many people required hospitalization and how many people died? And when you look at those 3 studies trying to use that same outcome measurement, what you found is that very, very few people, regardless of which vaccine it was, very few people, like in single digit numbers, required hospitalization or ICU care, and nobody died. So it's unfortunate that the 72% for Johnson & Johnson got as much media play because it's not the same outcome as the 94.5 that was used by Moderna and the 95 from Pfizer.
May I ask which one?
For your dad, which one's the best? The one he
Which
can
one
get
you
quicker.
took?
So I got Moderna because that was the only thing that was available to me.
Mm.
All right, so I got through the city health department. The Pfizer went to the hospitals. The city health department got Moderna, and then Johnson & Johnson just came. But that was all that was available to me, and I got it as quick as I could. Now I met 1B criteria, so that's how I was able to get it.
Okay.
Well, those are pretty much all of my questions. So thank you for your time.
Yep. I think if no one else has any questions, we can go ahead and kind of end our session today. I again really want to thank you, Dr. Persse, for spending your time with us. I know you had a lot of stuff going on today, but again, we really appreciate you giving us your time, your wisdom, answering, our bombardment of questions. I know it was a lot, but we really appreciate it, sir.
No, let me thank you. First of all, this is part of my job. So, getting the word out is obviously part of my job. By virtue of the fact that you folks are participating in this, you've defined yourself as community leaders. And so now the onus is on you. You need to take what you learned today and you need to go out and figure out how to get the word out to folks, right? Every time you do that and somebody listens to you, you're saving a life. And that sounds a little hokey maybe, but remember, one of my jobs is that I'm the medical director of the Houston Fire Department. And we've had several of our firefighters die from this. They're dead. These were, hardworking men who had families, and they got infected with a virus that they, in a million years, never thought would kill them. And their families never thought it would kill them, but it did. And in the series of transmissions of that virus before it got to that firefighter, somebody had to drop their guard. Somebody wasn't wearing a mask. Somebody was being lazy. Somebody didn't believe it. Somebody thought this is a bunch of hooey. Somebody let it get past them onto the next person. And we talk about in the city of Houston, we now have over 2,000 deaths. Well, 2,000 deaths, that's a statistic. Tony Searcy was a paramedic who I knew. Jerry Pacheco was a paramedic who I knew, and they are dead. And so when you go out there, you convince somebody to wear a mask or wash their hands or get vaccinated, you have probably saved a life. And I thank you for that.
If we could all kind of relay our thanks to Dr. Persse in the chat or come off mute, I think that would be great. But thank you again, sir.
Thank you.
Thank you so much for coming on and, sharing your knowledge with us. We really appreciate your time, and thank you for giving me such thorough answers as well.
Great. No,
Yeah.
no, thank you all.
Have a good evening.
Okay.
Okay.
Okay. Good night, everybody.
See you, Dr. Persse.